Good morning, everyone. Before starting the session, I would request all the participants to kindly fill the pre-test form. The link is given in the chat box and in the WhatsApp group. Good morning, everyone, again. A very warm welcome to all the attendees present here virtually. We are delighted to have you for today's Physiology Alumni Lecture Series 7, which is part of a similar Jubilee celebration of the MD Physiology program at Sri Ramachandra Medical College and Research Institute, Chennai. This monthly hybrid and online lecture initiative is designed to bring together our esteemed alumni, students, and faculty to share knowledge, inspire academic growth, and create a strong community of physiologists and intend to benefit the current postgraduates and physiology enthusiasts of our institution and nationwide. This program shall serve a bridge between the past and present, fostering inspiration, collaboration, and academic excellence between the alumni of Department of Physiology. By creating opportunities for alumni to contribute to the academic growth of their alma mater, PALS embodies the spirit of lifelong learning and professional development. Join us in celebrating this milestone and enriching the future of physiology education. It's a privilege to welcome Dr. K. Deepalakshmi ma'am to lead today's session. Before we proceed with the lecture, let us take a moment to learn more about her professional journey and significant contributions to the field. I now invite Dr. Pratibha to provide overview of Dr. K. Deepalakshmi ma'am's remarkable achievements and qualifications. Over to you, ma'am.
Yes, ma'am. Thank you, Maya. It is with great pride and joy that we welcome back one of our most distinguished alumni, Dr. K. Deepalakshmi, to deliver today's lecture in our Physiology Alumni Series 7. Dr. Deepalakshmi is currently the professor and head of the Department of Physiology at PSG Institute of Medical Sciences and Research, Coimbatore. She completed her MBBS at Tanjore Medical College in 2005 and her MD in Physiology at Sri Ramachandra Medical College from 2007 to 2010. She is a proud alumna of our own Department of Physiology. She has received the Feymer Fellowship with distinction in June 2016 from the PSG Famer Regional Institute and further enhanced her skills through the International Famer Competency Based Education Program organized by Famer. She is also a certified medical educator, having completed both the basic and advanced courses by the NNC. Dr. Deepalakshmi is a passionate researcher with 25 publications in well-known national and the international journals. Her key interests include gastrointestinal motility and the autonomic nervous system. She has undergone training in manometry procedures at SGPA Lucknow and now leads the GI motility lab at PSG. She was invited as a national faculty to present on biofeedback therapy at the 40th National Conference of the Association of Colon and the Rectal Surgeons of India, September 2017. She also received the Best Paper Award for her poster titled Pattern of Esophageal Motility in Patients with GERD at the 4th Biennial Conference of IMFDA held at KIMS Hospital, Secunderabad in April 2017. In addition to her clinical and research achievements, she is also actively involved in medical education. She is a core member of the Medical Educational Unit and serves on both the Curriculum Subcommittee and the Integrational Committees at the PSG Medical College, Coimbatore. Her dedication to teaching, research, and the clinical excellence makes her a true inspiration for students and the colleagues alike. Please join me in giving a warm welcome to Dr. K. Deepalakshmi as she shares her valuable insights and experiences with us today. Thank you.
Yes, means no noise. Yes. Am I audible? Yes. Okay. I'll share my screen. So I think I'm not able to share my screen. I think you can present my PPT.
Ma'am,
Yeah, you can share my PPT because I'm not
shall I
able
share
to
the
share it
PPT?
because yeah. Yes. Thank you. Yes,
Is it
good
seen,
morning.
ma'am?
Yeah. I'm able to see the. Yes. Okay. So shall I start? Shall I start my presentation?
Ma'am?
Shall I start my presentation?
Yeah, you may start, ma'am.
Okay.
And share the screen.
Yes, thank you. So, good morning, everyone. It's truly an honor to be part of this alumni lecture series. I'm deeply thankful to my alma mater that shaped me both personally and professionally. I would like to start this presentation by expressing my deep appreciation to Dr. Pratibha and team for this wonderful platform to share my expertise. So today we are going to see the rhythm of gut through manometry. Next slide, please. So the physiology of gastrointestinal motility is a marvel of biological engineering, which is driven by a complex and dynamic interplay of smooth muscle activity, intrinsic, that is enteric nervous system, which is modulated by autonomic nervous system, and it is also influenced by wide array of hormones and local paracrine factors. Each segment of GI tract possesses specialized motility patterns which is uniquely adapted to its specific functions, right from rapid propulsion through thorough mixing to efficient water absorption. So disruptions in the GI motility lead to a range of significant health impairments which affects the quality of life, highlighting the critical importance of balanced GI function. Next slide, please. So this presentation, we are going to have an overview of fundamentals of gastrointestinal motility, starting with neuromuscular control and motor functions of individual anatomical segments and pathophysiological mechanisms that underlie the motility disorders. Finally, we are going to visualize the GI motility through a specialized diagnostic tool called manometry, and also how these tests assist in diagnosing region-specific gastrointestinal conditions. Next slide, please. So gastrointestinal tract is a remarkable muscular tube which is approximately 7 meters in length in adults, extending from the esophagus to anus. As we all know, it is composed of 4 distinct layers, each contributing to the specialized functions. So the innermost layer is a mucosa, which is responsible for secretion and absorption. And next comes the submucosa, which contains blood vessels, lymphatic vessels, and nerves. And the muscularis externa. This is the primary layer for motility, which is composed of inner circular layer and an outer longitudinal layer. And these layers work in concert to produce the movements necessary for digestion. And finally, the outermost protective layer called serosa. So the entire GI tract is highly vascularized to support its metabolic demands and extensively innervated, reflecting its complex regulatory mechanism. Next slide, please. So the neuromuscular coordination is essential for proper functioning of GI tract. So the GI tract is composed of smooth muscle, which is of single unit type, with the cells connected by gap junctions, and this allows electrical signals to spread rapidly, enabling these synchronized contractions across the large segments of the gut. And the next one is the interstitial cells of Kajal. And these are the specialized cells which acts as a pacemaker of the gut, and they generate spontaneous rhythmic slow waves at a frequency of 3 to 12 waves per minute, which dictate maximum frequency of muscle contraction. Then comes our enteric nervous system, which is often called as brain of gut, and it is an intrinsic neural network within the GI wall. It includes myenteric or Auerbach's plexus, which controls the motility pattern and strength. and the submucosal or mesenous plexus, which regulates the local secretions and blood flow. And finally, the autonomic nervous system, which modulates this enteric nervous system activity. The parasympathetic system is generally excitatory in nature with acetylcholine as a neurotransmitter, and sympathetic system, which is generally inhibitory in nature with norepinephrine as a neurotransmitter. So this intricate neuromuscular coordination ensures efficient digestion, absorption of nutrients, and elimination of waste. So disruptions in this coordination lead to various gastrointestinal disorders, highlighting the importance of understanding and addressing these complex mechanisms. Next slide, please. So let's have a glimpse of hormonal and paracrine regulation of GI motility. So the first hormone is gastrin, which is released in response to food in stomach, and it is primarily stimulates gastric acid secretion and enhances gastric motility. And the next is cholecystokinin, which is secreted in small intestine, and it is crucial for digestion of fats and proteins. It inhibits the gastric emptying and stimulates gallbladder contraction to release the bile. And secretin, which is released in response to the acid chyme in the duodenum. It inhibits the gastric acid secretion and motility and stimulates bicarbonate release from the pancreas. And motilin, which is produced during fasting, and it is a key hormone that initiates the specialized movement called migrating motor complex. And finally, the serotonin, which is released by the enterochromaffin cells in the gut lining. Serotonin plays a vital role in activating various enteric nervous system reflexes, which influences both secretion and motility. Next slide, please. So the gastrointestinal tract uses variety of muscular contractions to move and mix the food during digestion. These movements are orchestrated by enteric nervous system with input from the central nervous system. So the key patterns of GI motility are peristalsis, segmentation, migrating motor complex, along with sphincter contraction and relaxation. So we are going to see the segment-specific movements. So first we'll see about the movements that are present in the esophagus. So the esophageal motility follows the swallowing reflex, which is a complex neuromuscular event with three phases, that is oral, pharyngeal, and esophageal. So the deglutition involves more than 22 muscles in the mouth, pharynx, and esophagus, which moves the food in the mouth through the upper esophageal sphincter and into the esophagus. So let's have a very brief note on the swallowing reflex. The tongue shapes and lubricates the bolus. Tongue voluntarily moves the bolus towards the back of the mouth, which will initiate the involuntary reflexive process. Then the mechanoreceptors present in the oropharynx gets activated. Afferents travel through the glossopharyngeal nerve to the swallowing centers in medulla and pons, and the motor efferents travel through the vagus nerves and stimulate the pharyngeal muscles, which will bring about the mechanism of the swallowing. That is, the base of the tongue compresses against the hard palate, which closes off the oropharynx from the rest of the mouth, and the soft palate moves upwards, which closes off the nasopharynx, and laryngeal muscles move forward and upward, which will close the airways. So the food will go and hitch the upper esophageal sphincter. So the upper esophageal sphincter first relax and then contract, which forces the food down into the esophagus. So the later contraction will prevent the immediate reflex from the esophagus. Okay, so stretch in the esophagus triggers the esophageal peristaltic wave. So here, two types of peristalsis occur. One is the primary peristalsis. It's a main propulsive wave, which is initiated by the act of swallowing. It travels down the esophagus, taking 8 to 10 seconds to reach the stomach. If the primary wave is insufficient or the food gets stuck, a reflexive secondary wave is triggered to clear the esophageal lumen. Then the lower esophageal sphincter, it is a muscular ring at the junction of esophagus and stomach. It will relax to allow the fluid to enter, and it contracts and it prevents the reflux of stomach contents back into the esophagus. A healthy lower esophageal sphincter maintains the physiological tone, that is, It is always contracted and it maintains a pressure of about 10 to 30 milliliter mercury. Next slide. So we'll see the neural mechanism and the hormone that influences the peristaltic movement. So peristalsis, as I said before, it's a propulsive way. It propels the contents forward and it involves the coordinated action of circular muscles behind the foot bolus and relaxation of the muscle ahead of it. So this creates a net forward movement. So acetylcholine causes constriction of the muscle just behind the footstep, while nitric oxide and gastrointestinal peptide causes a relaxation ahead of it. So this creates a pressure gradient forcing the foot downward. So the nerves from the enteric nervous system with the input from the autonomic nervous system coordinate the wave of constriction and relaxation. So peristalsis is prominent throughout GI tract, but especially it is present more in esophagus and intestine. So esophagus, the movement is about 2 to 4 centimeter. The velocity of movement is about 2 to 4 centimeter per second. It ensures one-way passage of food and waste. Okay, so next slide, please. And next is the movements that occur in the stomach. So the food now has reached the stomach. So what are the movements that occur in the stomach? So the first one is receptive relaxation. Upon swallowing, after traveling along the esophagus, the fundus of the stomach, the upper part of the stomach relaxes to accommodate the ingested food. So this allows the stomach to expand significantly, holding up to 1.5 liters of the content without significant increase in the pressure. So this we call it as a receptive relaxation. So I want to throw a question in this moment. So can you tell me in the chat box, which other organs exhibits this type of movement, receptive relaxation? That is, without increase in the pressure, there will be relaxation. Can you type some of the movements in the chat box? Yes, very good. Bladder. Yes, any other organ? Yes, urinary bladder. Excellent. Any other hollow organ? Okay, fine. Yes, thank you. Thank you for the response. Okay. So the next movement is mixing and churning. Okay, so the body and antrum of the stomach generate strong rhythmic contractions. That is 3 to 4 waves per minute. We call it as segmentation contractions, which are primarily responsible for mixing. So they involve alternating local contractions and relaxation of the circular muscle, which effectively churns the chyme. So chyme is nothing but the food substances that is mixed up with the gastric acid secretion. So here the segmentation contraction occurs without significant forward movement, where the peristalsis focuses on propelling the foot forward. So here the primary role of segmentation contraction is to mix the chyme and facilitates the digestion and absorption. So it is more prominent in small intestine, but also occurs in large intestine. So here the frequency differs in each segment. So duodenum, it has 12 contractions per minute, ileum, 8 contractions per minute. So it ensures the thorough mixing of chyme with digestive enzymes to facilitate absorption. So then the final movement in the gastric compound is gastric emptying. The pyloric sphincter at the base of the stomach precisely controls the release of chyme into the small intestine. Typically about 3 ml of chyme is released with each contraction. The emptying rate differs with each component. So the liquid empties faster within 20 minutes than the solids, which takes about 2 to 4 hours. So the emptying rate is carefully regulated by our feedback from the duodenum, and it is also sensitive to fat, acid, and osmolarity. So next slide, please. So the next fascinating movement is migrating motor complex. So it's an interdigestive motility. Here it is a distinct pattern of electromechanical activity that occurs in the stomach and small intestine during the periods of fasting, which is often interrupted by feeding. So it has phases, 3 phases. So the MMC cycles through several phases, typically lasting for around 90 minutes. So the phase 1, it's a period of quiescence or minimal activity, and phase 2 is characterized by increasing but irregular contractions. And phase 3, it consists of strong rhythmic contractions that propagate caudally, sweeping undigested materials, bacteria, and residual secretions towards the colon. And phase 4 is a very brief transition phase back to quiescence. So you can see here. These are the phase 3 contractions. Okay. So this function of MMC is to serve as a intestinal housekeeper, which clears the small intestine of debris and preventing bacterial overgrowth. Particularly important in preventing the conditions like SIBO. SIBO is nothing but small intestinal bacterial overgrowth. It also prepares the GI tract for next meal. Next slide, please. So we have come to the end of the physiology of motility, that is large intestinal motility. It facilitates water absorption and elimination. Here the types of movements are the haustral churning. So the large intestine exhibits slow rhythmic mixing movement. We call it as haustral churning, which occurs every 30 to 60 minutes. And these contractions primarily aid in the absorption of water and electrolytes from the remaining chyme and compacting the fecal matter. So then comes your mass movements, which is infrequent but powerful propulsive contractions known as mass movements, which occur typically 3 to 4 times per day. And these strong contractions push the contents from the transverse colon towards the rectum, which prepares for defecation process, and they are often triggered by the gastrocolic reflex. Then comes your defecation reflex. When the fecal matter distends the rectum, it triggers the defecation reflex. Feces stretch the rectum, stimulate the stretch receptors, transmitting the signal to the spinal cord. The spinal reflex sends parasympathetic motor signals to the myotic nerve plexus, resulting in the contraction of the smooth muscles within the rectum and pushing the feces downwards. Same spinal reflex also sends parasympathetic motor signals to relax the internal anal sphincter. The voluntary impulses from the brain prevent defecation by keeping external anal sphincter contracted. So defecation will occur if voluntary signals allow the external sphincter to relax. So finally, about the transit time. So the transit time through the large intestine varies significantly among individuals, ranging from 12 to 72 hours, which are influenced by the factors such as diet, hydration, and fiber intake. Next slide, please. So this is about the sphincter contraction and relaxation. So this is also one of the functional component which helps in the normal GI motility. So here the sphincters, you have pyloric sphincter, lower esophageal sphincter. Okay, so the sphincters are nothing but the circular bands of smooth muscle that are normally contracted at baseline, keeping the footstep from passing into the next segment of the tract. So usually the sphincter relaxation is regulated all along the tract, and the baseline contraction is maintained by enkephalin, which is a neurotransmitter in the enteric nervous system, and it demonstrates the ability of the smooth muscle to maintain a latch bit state. I think you all know about this. The latch bit state is nothing but a state in which the myosin is dephosphorylated. However, it remains, that is, no longer cross bit cycle occurs. However, it remains attached to the actin, which maintains the same tension. So this allows the muscle to maintain the tone without expending much energy. So this and the relaxation of the sphincter is triggered by vasointestinal peptide. So this is about sphincter contraction and relaxation. Next slide, please. Okay. So why? So we have seen the physiology of motility and what are the nervous regulations and what are the regulatory mechanisms involving the neural and the muscular component. So now we move on to the motility testing. So we are going to visualize the GI motility through manometry. What is the significance of this motility testing? Why this motility tests are important? First, to distinguish the overlapping symptoms. So many GI disorders present with similar symptoms like abdominal pain, bloating, nausea. So making accurate diagnosis becomes challenging based on the symptoms alone. So they will be whether they have the lower GI or upper GI pathology, they will be presenting with some vague symptoms. So with the symptoms alone, we can't specifically diagnose the disease. And you have to identify the underlying cause in order to treat it better. So the motility testing will provide you the objective data about how the GI tract is functioning, helping to differentiate between various motility disorders and rule out the other conditions such as malignancies and inflammatory disorders. Then this motility testing will also guide in treatment strategies. So the motility test help to identify the specific area, specific segment involved, that is stomach, small intestine or colon, and type of motility junction, which will allow for the targeted therapies like medications, dietary modifications, or even surgical interventions. Then you can predict the treatment responsiveness also. So with the help of motility test, you can predict how the patients with conditions like functional dyspepsia respond to specific treatments, including antidepressant medications. Then you can optimize the patient outcomes. That is, the studies show a correlation between assessing motility and improved outcomes, particularly in areas like surgical recovery and identifying the best clinical markers for discharge. So in essence, GI motility assessment is a valuable tool in gastroenterology, allowing the clinicians to make precise diagnosis, tailor treatment plans, monitor disease progression, and ultimately improve patient care and outcomes. Next slide, please. So let's move on to the next part of our presentation, gastrointestinal motility assessment by manometry. Next slide, please. So here the manometry, how it evolved. So the high resolution manometry is now replacing the conventional manometry. So in the clinical evaluation of patients with GI symptoms. So the first concept was invented in 1950s, and the continuous technical modifications occurring today have improved the measuring techniques. So first, the pressure recordings of the esophagus were performed using water perfused catheters. First, the pressure recordings of esophagus were performed using water perfused catheters with 1 or 2 few side holes in it. After which 4 to 8 side holes became common. So the conventional manometry uses pressure sensors which are spaced 5 to 7 centimeter apart, which reduces the diagnostic precision and provides limited detail about the esophageal pressure patterns. So this technique is technologically complex, and these findings also lack the detailed waveform analysis, were insufficient for systemic classification of GI disorders. Now the high resolution manometry, a more advanced diagnostic tool, offers significant improvement over conventional techniques. Here in HRM, it measures the pressure at 1 centimeter intervals, enabling more accurate assessment of GI motility. So the HRM also allows a detailed waveform analysis and standardized classification of motility disorders, which will facilitate the earlier and more precise diagnosis. So moreover, the intraluminal pressure is viewed as a continuum of isocaloric regions indicating isobaric conditions. So you can see in this picture, and these are the conventional tubes with, this is a water perfused catheter and this is a solid state catheter. So these are the catheters used for acquiring the biosignals in the GI tract. And you can see this is the conventional manometry graphing where the waveforms are present. It is very much difficult to analysis for analyzing the report. Where this HRM analysis, they have the graph has come with a isobaric. Baric means pressure. Okay, so some pressure gradients, topographic pressure gradients. So with the help of this color plots, we'll be able to analyze it easier than the conventional manometry waveforms. Next slide, please. So the introduction of HRM gave rise to new objective metrics and recognizable patterns of GI motor function, utilizing a classification scheme. So here the Chicago classification is used for esophageal motility disorders, whereas London classification is for lower GI motility disorders. So with the help of this classification, it is being evolved. The versions are, the classification is getting upgraded, and with the help of this classification, we can diagnose the motility pattern in a proper way. The visual presentation of the acquired data is in the form of isocaloric regions indicating the isobaric conditions. So in the previous slide I showed the HRM, it shows the graph in the form of, it shows the pattern of GI motility in the form of isobaric color plots. So this led to the more sensitive, accurate and objective analysis of GI motility. So in terms of instrument setup, so the manometry system, it includes a catheter that detects the intraluminal pressure at multiple points along the gastrointestinal tract. There are two types of catheter. In the previous slide I showed solid state catheter, which has an inbuilt miniature pressure sensors, and water perfused catheter, which are connected to the external pressure transducers and continuously perfused with water. So here the high resolution manometry catheters are typically, it contains more sensors, more number of sensors, that is 20 to 36 sensors, which are closely spaced for detailed pressure mapping. So this system includes, along with the catheter, it has a recording device with a software. So this computer or monitor that displays a real-time pressure data in the form of color-coded topographic plots, along with a software that supports the calibration, real-time monitoring, data recording and analysis. So you can see here, you can see the monitor displaying the topographic color plots. So here the technician is introducing a catheter into the patients. That is, the catheter will be introduced transnasally. So the catheter will be introduced transnasally. So you can see the monitor displaying the color plots, which depicts the intraluminal pressure changes. Next slide, please. So what is the principle of manometry? I told the catheter has sensors. So you can see the sensors. This is a catheter, and you can see that these dots represents the sensors. You can see the pressure sensors. Okay. So when the catheter is in the esophagus, the peristalsis occurs. When the peristalsis occurs, the side wall gets compressed and the water flow stops. So this change in the pressure will be recorded as a color plotter. The information will be obtained as a topographic color plotter. So you can see the pressure changes that are detected by the sensors on the catheter, which are converted into electrical signals, which are then recorded, visualized and analyzed. Next slide, please. So different types of manometry target specific gastrointestinal regions, helping to distinguish between neuromuscular dysfunctions that cause the symptoms like dysphagia, bloating, chronic constipation and incontinence. So first one is the esophageal manometry. which assesses the functional status of lower and upper esophageal sphincter and pattern of motility. And next comes the anteroduodenal motility, anteroduodenal manometry, which assesses the gastric and small intestinal contractile patterns. And next is your anorectal manometry, which evaluates the functional integrity of the rectum and anal sphincters. Next slide, please. Next slide. So this is a video showing the esophageal pattern. You're able to operate the video. Can you stop sharing? Shall I try sharing the video? Sharing the video alone. Yes. Yes. Now it's moving. Yes. So here you can see. So this upper and the lower pressure bands. It represents the upper esophageal sphincter, and this is lower esophageal sphincter. Okay, so initially what we will do after introducing the catheter, after placing the catheter in the OG junction, we used to visualize the upper and lower esophageal sphincter, and this blue color, it indicates the negative pressure which is present in the thoracic, that is transthoracic pressure. Okay. And this is the motility, propagative motility pattern that occurs in the esophageal tube. Can you play the video again? So here you can see, initially for 30 seconds we used to record the basal sphincter pressures, that is upper and lower esophageal sphincter, and the patient will be instructed not to swallow during this period. After that, we will give a swallow. That is, you can see the opening of the upper esophageal sphincter. At the same time, you can see the opening of the lower esophageal sphincter. And this is the propagative pattern of esophageal motility. Okay. So here, this is the proximal limit where the striated muscles changes into smooth muscle. Okay. So this we call it as propagative motility pattern, which is normal. So now you are in this video, you are seeing the normal esophageal motility pattern and the normal upper and lower esophageal sphincter pressures. Okay, so with the help of this color codes, we'll be able to analyze whether the pressure has decreased or increased. Okay, next slide, please. So the parameters which provide the objective and detailed assessment of esophageal motility includes integrated relaxation pressure, which is nothing but adequacy of deglutitive relaxation of the lower esophageal sphincter. So it is defined as the lowest mean axial pressure, which is recorded over a 4-second period within the 10 seconds following a swallow. So you can see here, and this area we call it as integrated relaxation pressure. So after a swallow, that is after the upper esophageal sphincter has opened, here you can see the opening of the lower esophageal sphincter also. So this area, the pressure in this area is recorded as integrated relaxation pressure. So which is the normal pressure should be less than 50 millimeter mercury. In the case of achalasia cardia, where the lower esophageal sphincter fails to relax, in that case, what will happen? There will be you won't be able to see the opening here. It will be continuous and the pressure will be increased. It will be more than 15 millimeter mercury. And the next parameter is the distal contractile integral. Next parameter will be distal contractile integral. It quantifies the vigor of esophageal contractions. So it is calculated as a product of amplitude, duration, and length of the distal esophageal contraction. So the distal esophageal contraction is nothing but this one. So this area we call it as distal esophageal contraction, near the lower esophageal sphincter. So here the pressure exceeds 20 millimeter mercury. Okay, so the normal range of distal contractile integral is between 450 to 5000 millimeter mercury seconds per centimeter. The next parameter is contractile deceleration point. It's nothing but it represents the inflection point on the isobaric contour, where the esophageal peristaltic velocity slows down and marking the transition from the peristaltic propagation to ampullary emptying. So it's nothing but this point where the bolus gets transferred into the stomach. So this green shadow indicates the stomach, and this is the area where the velocity will go down. The velocity of propagative contraction will decrease, and it causes the transfer of the bolus from the esophageal tube to the stomach. So this area we call it as contractile deceleration point. So the next parameter is the distal latency. It is a time interval between the onset of upper esophageal sphincter relaxation and the CDP. So here this is the upper esophageal relaxation. So this is this area. So up to this area we call it as distal latency. So the normally it is about, it should be more than 4.5 seconds. Then next is the esophageal pressurization. Esophageal pressurization is nothing but it evaluates the intrabolus pressurization patterns. So it occurs when the swallowed liquid becomes trapped between the two contracting segments. So it is abnormal when the pressurization is above 30 millimeter mercury. So with the help of these parameters, we can diagnose the esophageal motility disorders. Okay, so this integrated relaxation pressure, with the help of this, we can measure the lower esophageal sphincter pressure and the pattern of relaxation and contraction during swallowing. Distal contractile integral, contractile deceleration point, distal latency, and esophageal pressurization. All these parameters will help to analyze the motility pattern of the esophagus, that is peristaltic pattern. Next slide, please. So next we move on to antropyloroduodenal manometry. So it is designed to evaluate the pressure activity in the antrum, pylorus, and duodenum. So now the food has reached the stomach. From the esophagus, it has reached the stomach. So it aids this antropyloroduodenal manometry. It aids in diagnosing disorders involving gastroduodenal coordination, such as gastroparesis, chronic intestinal pseudo-obstruction, and pyloric dysfunction. So this procedure utilizes the water perfusion system, and it employs a custom-made 12-channel catheter. So for esophageal, I told it is 16 to 24-channel catheter will be used. Here in antropyloroduodenal manometry, we are using 12-channel catheter. Here each channel is marked with radio-opaque marker. So this is somewhat cumbersome procedure, time-consuming also. So here each channel is marked with radio-opaque markers to enable the precise anatomical location under the fluoroscopic guidance. Okay. So here the catheter will be inserted transnasally, and it is carefully advanced through the stomach into the duodenum with real-time imaging support. So its positioning is such that proximal sensors will capture the antral contractile activity, where midline sensor will assess the pyloric sphincter pressure, and distal sensors will evaluate duodenal motility. So here the proper placement of the catheter is very much important. So it will be verified fluoroscopically through the radio-opaque markers. Okay, so how we are going to assess it? So you have to do two recordings. One is during the fasting phase, for about 3 to 6 hours, which allows the assessment of presence and pattern of migrating motor complexes. So which will reflect the baseline gastrointestinal motility in the fasting state. So you can see here. So this is the recording we got during the fasting phase. Then you have to give the patient the standardized meal. Then after that you have to record the postprandial phase, which is usually for 2 hours, which evaluates the motor response to a standardized meal, focusing on the coordination of antral, pyloric and diurnal contractions in the fed state. So the presence of phase 3 MMCs during fasting and coordinated antropylorodiurnal contractions after meal indicates normal motility. Okay, so this is the normal finding we used to see in the antropylorodiurnal manometry. If gastroparesis, the gastroparesis is a common finding in the diabetes mellitus patients. So here the gastroparesis is characterized by diminished antral contractions and inadequate pyloric relaxation. So the gastric emptying will be delayed. Then pylorospasm. Pylorospasm is one of the condition we can diagnose with the help of the antropylorodiurnal manometry. It is identified by elevated pyloric pressures and impaired pyloric opening. Then chronic intestinal pseudo-obstruction is marked by absence of MMC. MMC won't be present in the pseudo-obstruction. And you can also see disorganized or ineffective diurnal contractions. Okay, so here you can see the postprandial contractions. So here the contractions are more here. Okay, so this is the manometry graph. Recording shows the postprandial phase. Okay, so this is about antropylorodiurnal manometry. Next slide, please. So next is your high resolution anorectal manometry. So the high resolution anorectal manometry is a diagnostic test which is used to evaluate the functional integrity of rectum and anal sphincters. So the HRAM will be performed in participants presenting with defecatory disorders. Here the 16-channel water perfusion system is used. Here anorectal manometry catheter is about 4.2 millimeter in diameter, having 16 radial ports. Here the arrangement is somewhat different. A latex balloon will be tied at the tip of the manometry catheter. So here it is used for assess the expulsion test and rectal sensory testing. So the lower GI motility disorders will be classified using London classification. For esophagus, we are using Chicago classification. Here for GI motility, lower GI motility disorders, we are using London classification. No bowel preparation is needed for this HRAM. Here the participants will be studied in the left lateral decubitus position with knee and hips flexed. Radial catheter with multi-channel circumferential sensors will be placed at, which are spaced at 0.5 centimeter intervals, will be gently inserted to inside the anal verge. So after over 5 minutes of making the patient comfortable and allowing the pressures to stabilize, the following parameters will be measured. So you can see here, this is a normal recording of the anorectal area. So you can see this is the color band which represents the anal sphincters. So you can see the pink color. Always here you can see the color coding here. So this black is somewhat abnormal and this pink color code represents the normal pressures, whether it is esophagus or anorectal manometry. The pink color represents the normal one and the black color represents the higher values, and the yellow and the blue color, it represents the lower values. Okay, so this is the anal sphincter pressure, and you can see this is the rectal area, and this is the internal anal sphincter. Next slide, please. So this is a video, you can play the video which shows the anorectal measurements. You're able to play the video? Yeah, yes. So now you are able to see here. See, this is, you can see the prompts here: relax, push, relax. Okay, so here we are recording the defecatory maneuver. Okay, so this defecatory maneuver, during defecatory maneuver, the patient has to increase the rectal pressure and they have to relax their internal sphincter. Here, when this should be done at the same time. Rectal pressure should be increased. At the same time, the anal sphincter pressure should be decreased. But here in this patient, you can see the incoordination. So here the rectal pressure increase is seen, but he is closing the sphincters, internal sphincters. Here you can see the black color here, which indicates the higher pressure. It is not normal. Okay. So you can play the video again, please. So here it is a hypertensive sphincter. In the previous slide, you would have noticed it is pink in color. This shows the, so this is normal. This is normal pressure. You can see the pink color. Okay. So here, push in the sense they have to mimic as if they are defecating. So increasing the rectal pressure, and at the same time the anal pressure should decrease. Anal sphincter pressure should decrease. Okay, thank you. Next slide. So here there are, we will see the parameters of anorectal manometry. So first we have to record the anorectal resting pressure or basal sphincter pressure. Here this activity will be recorded over 60 seconds. Then you have to ask the patient to do the voluntary contraction, that is squeeze the sphincters. Okay, so the participant will be asked to squeeze the sphincter continuously for 8 to 10 seconds, which is followed by a resting lapse at least for 30 seconds. So this indicates the external sphincter activity. So you can see here, this is at rest. This is at rest, the anal sphincter pressure at rest, and during squeeze. Okay, you can see the increased pressure here. So the next is cough maneuver. Okay, so you have to ask the patient to cough. So here the recto-anal contractile reflex will be assessed. So there will be changes in the intra-anal and intra-rectal pressures will be measured. So which help to assess the extrinsic nerve supply integrity. So you can see here, this is a cough maneuver. So during cough, the rectal pressure is increasing. At the same time, the anal sphincters pressure also increasing. Okay, so this is cough maneuver, whether they are able to hold. The next is the defecatory maneuver. This is what we saw in the video. Okay, so this is bearing down or defecatory maneuver. So during bearing down or mimicking the defecation maneuver, there will be increase in the rectal pressure followed by reduction in the sphincter pressure. Here this is a normal finding. In the video we saw the abnormal one where there is increase in the internal anal sphincter also. So this defecatory maneuver gives the impression of recto-anal coordination. Okay, so there should be a recto-anal coordination for defecation. So if there is any problem with this resting pressure, if the resting pressure is increased, or they don't have the coordination, recto-anal coordination during defecatory maneuver, we will be giving them the biofeedback therapy. The biofeedback therapy is nothing but it's like an exercise. We used to teach the patient how to coordinate the rectal and sphincters. Okay, so they have the for 3 or 4 sittings. We will have it as a package. So they have to come and they have to see the monitor. So we will be introducing the sphincters. So the patient will be seeing the monitor. The patient will be seeing the monitor, and they have to do this maneuver on seeing the monitor. That is, there will be increase in the rectal pressure. Then they have to open the internal sphincters. Okay, so biofeedback therapy will be given to the patients, those who are having hypertensive sphincter and rectoanal incoordination. Then this is a very, very important reflex we used to assess with the help of anorectal manometry, that is rectoanal inhibitory reflex. Okay, we have to, I told that balloon will be tied at the tip of the catheter. So we used to introduce some air inside that balloon. Okay, so when we are introducing 30 ml of air, there should be 25, more than 25% of reduction in the baseline pressure will be observed. So this shows the presence of rectoanal inhibitory reflex. Okay, so this will be absent in Hirschsprung's disease. Okay, we call it as megacolon, where there is a problem with the intrinsic innervation. And we used to measure the rectal sensitivity. So whether they are hypersensitive or hyposensitive. Okay, so we used to introduce air inside the balloon and we'll ask for the first sensation. Okay, so the first sensation, that is more than 20 ml, should be normal for both the genders, and we keep on increasing the air level. So when they are having urge to defecate, we used to ask the patient if the normal is more than 80 ml for male and more than 60 ml for female, and the maximum tolerable limit will be assessed. Okay, we keep on increasing. So more than 126 ml is abnormally high. Okay, then we used to do the balloon expulsion test. So we used to fill the balloon with 50 ml of air and ask the patient to push the balloon out. They will be given 1 minute time for that. So within 1 minute, within 16 seconds, they have to expel the balloon. Okay, so these are the parameters we used to assess in anorectal manometry. Next slide, please. So I'm showing some of the abnormal manometry finding. You can see the achalasia. So if you remember the normal esophageal manometry graph, here you can see this is upper esophageal sphincter. Here the pressure of the upper esophageal sphincter is more, and this is lower esophageal sphincter, and this is the intrathoracic pressure, where in the normal you would have seen in blue color. But here you can see, then you can see the opening during swallowing. Opening is there. In the normal propagative motility will be like this. Here you can see the simultaneous motility. The motility pattern is somewhat abnormal. We can say these yellow shadows. There is stasis. Stasis of food will be seen as this yellow shadows. So this depicts achalasia cardia, where there is failure of LES opening. And here this pattern is esophagogastric outlet obstruction. So you can see the distal end of the propagative motility. Here you can see the increased pressure in the distal segment. So this we call it as esophagogastric outflow obstruction. So these kind of findings, the patients with this kind of findings, they will evolve to achalasia cardia. So anybody can type in the chat what is the recent intervention for this achalasia cardia, and what was the older one, and what is the newer intervention now they are following for achalasia cardia. Can have a try. See here, what is the older one? What is the surgical intervention usually done to relax the lower esophageal sphincter? Heard of Keller's myotomy? Yes, myotomy. Yes, right. That was the older one. Now, so it's somewhat a major surgical procedure. That's Keller's myotomy. They used to do. Do a surgical intervention which will relax the tight ileus. But now endoscopic procedure. They are doing medical gastroenterologist itself. They are performing this intervention. It is a daycare procedure. Anybody knows the name? It's POEM. 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 Peroral endoscopic myotomy. Peroral endoscopic resection. So with the help of endoscopy itself, they used to resect the part of ileus. Okay. So next slide, please. So you can see the contraction patterns here. So here we call it as this is premature. Next slide, please. Yes. So here you can see the contraction patterns. So this is premature contraction. Then you won't be able to see the motility pattern here. So we call it as fragmented peristalsis. This is not a normal peristalsis. The normal peristalsis will be in the propagative pattern. Here the motility shadow is missing. So we call it as fragmented peristalsis. So with the help of DL, distal latency, and DCI, we can categorize this contraction pattern into premature and fragmented. Next slide, please. Next is weak peristalsis and failed peristalsis. So the patient with scleroderma. So they used to show the low amplitude and non-peristaltic contractions in the distal esophagus, as well as reduction in the lower esophageal sphincter pressure. So you can see here the lower esophageal sphincter pressure is very less. You can see here. So if it is normal, it will be pink in color. Okay. So the normal pressure, what I told is 10 to 30. So it is below 10. So you can see the yellow markings, yellow color code. Okay. So this is, with this we call it as weak peristalsis and failed peristalsis, contraction vigor. So with the help of DCI, you can diagnose this condition. So usually it is seen in scleroderma patients. So we call this weak peristalsis, failed peristalsis, premature contraction, everything together as ineffective esophageal motility. So here the motility pattern, the motor function of the esophagus is not normal. So we call it as ineffective esophageal motility. The next slide, please. Sometimes you can see a break in the peristaltic pattern. So this we call it as a break. Okay. So the small break is about 2 to 5 centimeter, and the larger break is more than 5 centimeter. Yes. Next slide, please. So the next one is anorectal manometry. So here you can see the black color here. So it is hypertensive. You can see the black color here. This is hypertensive. So you can see this is hypertensive. Normally the patients suffering from chronic constipation, they'll be having hypertensive sphincter. So I told we used to give biofeedback therapy with the help of this manometry. So they used to see the monitor and they will try to relax their sphincters by increasing the rectal pressure. So here this is rectum. So this area is rectal area. So they have to increase the rectal pressure and they have to open the internal sphincters. Okay. Then hypotensive. So patients suffering from incontinence, they used to have a hypotensive sphincter. So here you can see the green and yellow marking. It is not pink. So the pressure is reduced. So hypotensive sphincter. Yes. Next slide, please. So this is again a video. So here yes. So here you can see the sphincter. See, this is not normal. This is not normal pattern of motility. This we call it a simultaneous motility. Okay, simultaneous pattern of motility. You can see the stasis here. Without opening, also you can see the stasis of the, but the LES pressure seems to be normal. So the motility pattern is abnormal here. So this is simultaneous motility. Here you can see the opening of the upper esophageal sphincter. Here the lower esophageal sphincter is incompletely open, does not open fully. So at the same time, when the upper esophageal sphincter opens, the lower esophageal sphincter should also open. Here you can see the incomplete relaxation of LES. Okay, so this is a case of achalasia cardia, where you can see the simultaneous motility pattern with incomplete relaxation of LES and stasis. Okay. Yes, next slide, please. That's it. Yes, thank you for patient listening. Do you have any doubts you have? I'm able to see a comment in the chat box that not able to see the pointer when madam is explaining. You want which video to be explained? I will show it again. Any doubts?
Thank you, Dr. Deepa.
Okay. Are you able to hear? Please.
Hi, Deepa.
Hi, Abhi. Thank you. Thank you for the opportunity.
Thank you so much for joining us and sharing your special expertise on this gut manometry and also discussing the basic concepts very lucidly. Thank you for joining. We have a formal vote of thanks. Thank you so much.
Thank you so much, Dr. K. Deepalakshmi ma'am, for that insightful and enlightening session. Your deep dive into the rhythm of gut, exploring motility with manometry, has truly enhanced our understanding of this critical process. Now, we would like to open the floor for the audience. If you have any questions, you may post it in the chat box.
is contraindications of manometry. Those who are having the mass ulcers, bleeding tendencies, and so they are contraindicated. Any erosive lesions in the GI tract. These are the contraindications. Patients with GERD secondary to ineffective esophageal motility, what would be the management? So here, if there is ineffective motility, they used to manage medically. If there is a lax LES, if the LES is not maintaining the pressure, as I told, it is 10 to 30. If the LES pressure is below 10, they used to do fundoplication. So they used to do fundoplication. Then we will do, after fundoplication, we will do the follow-up manometry in order to assess the LES sphincter pressure. Ineffective motility, they have to will be treated medically only.
Thank you, ma'am. A big thanks to the Department of Physiology for organizing this initiative and to all the participants for your enthusiasm and engagement. Your presence and interaction makes PALS a vibrant platform for learning and knowledge sharing. We hope today's session has inspired new ideas and reinforced the importance of staying connected with our alumni network. Let's continue to learn, collaborate, and contribute to the growth of physiology as a field.
Thank you, Deepa. Thank you so much.
Thank you, Dr. Abhinami. Thank you for the opportunity.
Thank you. Thank you. If there are no queries, we have put up the post-test as well as the feedback form. Kindly fill up those forms. Thank you all for joining us.
Okay.
Mike.
Before we wrap up, a quick reminder to the participants. E-certificates will be provided to all the registered participants. Post-test and feedback link is posted in the chat box. Kindly fill the same. And stay tuned for upcoming PALS lecture series. Thank you once again, and we look forward to seeing you in the next session. Have a great day ahead. Thank you all.